Hey everyone, my name's Bonnie. I am an educator in the medical ICU, and today we're going to be talking a little bit about the pulmonary system and respiratory care in the critical care environment. So for the purposes of today, what I'm going to go ahead and do is just hide this video panel off to the side. And during this presentation, we're going to use this PowerPoint slides, but also I'm going to kind of toggle between this PowerPoint and a function in Zoom called the whiteboard, which basically allows me to perhaps draw or expand on any information that I think might be a little bit confusing or need some further explanation. So right now we're going to go back to the PowerPoint and we're going to go ahead and get started. I don't know why it logs me out like that. All right, so I'm not going to read these objectives to you. But what we're going to talk about today is essentially modes of oxygen delivery, ventilation delivery. We're going to talk a little bit about mechanical ventilation, a little bit about artificial airways, including tracheostomies and blood gases. And hopefully I'll be able to answer some questions that you guys have. If a question comes up and you want to reach out, you're more than welcome to ask it. And I will answer it to the best of my ability. If there's something that you think would have been really helpful for me to talk about that I did not discuss, please let me know. I'm happy to make addendums and modify this talk. Okay, so basically when I teach about mechanical ventilation, I like to narrow it down and very simply state that there are essentially three primary reasons that somebody would need to be put on a mechanical ventilator. Okay, we're going to talk about some of those reasons throughout this presentation. But when someone needs to be put on a mechanical ventilator, they are either having a problem with their oxygenation, and they may be having a problem with their ventilation, or they're having trouble protecting their airway, or maybe some combination of all three of those things. So what we'll do is we'll first talk a little bit about oxygen delivery. And after we look at some of these definitions, and then we'll move through the other two. So looking at oxygenation. Oxygenation is, and this is a really great definition, so I'm going to read it a couple times. The ability and process of obtaining oxygen from the environment and the body's ability to make it available for the rest of the tissues and organs in the body. Okay, so that's very different than ventilation. Now, when I was an acute care nurse, I thought a lot about oxygenation, right? This is easy to measure. We can do it quickly. I, check a pulse ox and kind of see what somebody's oxygenation is. I was very familiar with ways to deliver oxygenation, but I never really spent much time thinking about ventilation, which is very different. So ventilation is the movement of air in and out of the lungs, okay? So we're going to start with oxygenation. And I know that some of you guys may be very, very familiar with oxygenation. And so I may skip through some of it a little quickly. And if you have questions, like I said, please just let me know. I'm happy to answer those as I can. So oxygenation, once again, this is the ability and the process of obtaining oxygen from the environment. Now, whether that environment is, you're in atmospheric air, there's 21% oxygen available to us, or the environment is we're delivering 100% oxygen and you're on the ventilator, and anything in between. Okay, so the ability and the process of obtaining oxygen from the environment and the body's ability to make it available for the rest of the tissues and the organs in the body. So can I bring oxygen into my body and circulate it around to the tissues and the organs that need that oxygen in order to function? Okay, so that's a pretty big role. So we're going to look at ways that we can deliver oxygen, ways that we can increase oxygen, and the kind of flow that I'm going to follow is going to be sort of least to most oxygen delivery, and we'll end a little bit with mechanical ventilation and talk about ventilator basics, which probably the majority of you have not spent a whole lot of time learning about mechanical ventilation. So I'm excited to be able to kind of cross that bridge with you guys. Okay, so starting off simple, nasal cannula. Most of you guys probably extremely familiar with nasal cannula, so I'm not going to read to you about that. As we escalate, we're going to move into the Venturi and the simple face mask. So a little bit higher, you know, nasal cannulas doing an FiO2 of 44%. Venturi simple face mask, we're going to go up to 60%. And if you haven't used a Venturi, it comes with, if you look over to the right, these little colorful adapters down here. Each of these colorful adapters actually correlates with a different concentration of FiO2 that's provided. So if you look kind of at the bottom side down here, you'll actually see that number, and it will tell you how many liters to put your flow meter on at the wall. Okay, and you'll notice on each of these modes of delivery, I'll put something, you know, like no water bottle needed down here. The rule of thumb for this is if they're breathing through their mouth, the oxygen really doesn't necessarily need to be humidified. Our mouths tend to be pretty capable of humidifying air that we take in. If it's going through your nose, though the nose will get the, you know, get the air that's moving through kind of humidified, we really don't want that nose to get super, super dry, because what happens when we get really dry airs is they tend to bleed. So anything that's going through the nose, most likely, it really needs to be humidified. And then if you have a patient who has a tracheostomy and you're delivering oxygen through that tracheostomy, it's very important that be humidified, because we're really bypassing all of those structures in the very, very upper part, you know, the nose and the mouth, that their primary function there is really to humidify that air. So very important that we humidify when we have a tracheostomy. Okay, so we've covered nasal cannula, Venturi simple face mask. Next, we're going to move on to a rebreather. So when I hear people talking about rebreathers, for the most part, what they're referring to is a non-rebreather, okay? There is also a partial non-rebreather. This is the exact same piece of equipment. The only difference is if you look over here on the right, you'll see two stickers on this, or you'll see a sticker here on this side for the non-rebreather. On the partial rebreather, you'll notice that these little discs have been removed, and that's pretty much the only difference from a nursing standpoint. Something that is helpful, you'll notice, the non-rebreather, of course, gives us a little bit more FiO2 than the partial non-rebreather does. And something that, you know, I wasn't really aware of for quite some time was that it actually, in this situation, is quite important to set the flow meter somewhere between 10 and 15 liters. If we set it too low or too high, either the reservoir bag either won't inflate or it will be hyperinflated, and what ends up happening is that either the patient's not getting the oxygen that they need, perhaps they're, you know, rebreathing their CO2, which we don't want them to do. We don't want them to be breathing in their carbon dioxide. So just something to make a note of is that really does need to be between 10 and 15 liters. For the most part, when we use non-rebreathers, this is somewhat of a rescue treatment. It's not typically something that we're going to leave somebody on for, you know, days and days, unless, of course, you know, that's their wish, and they're, you know, don't want to be intubated and don't want to escalate past that, and they're more of a palliative management. But for the most part, if somebody's really needing this therapy, they're requiring quite a bit of oxygenation, you know, up to 80%. And so we need to be thinking about, you know, what are the next steps in managing this individual. Okay, so a couple other modes of oxygen delivery, a trach collar. So this is for patients who do have tracheostomies, but are not needing to be put on mechanical ventilation. So depending on where you work, you may or may not have experience with tracheostomies. You may be very comfortable with them. You may have never seen one. Pretty importantly, which I've kind of already talked a little bit about, is that these really need to be humidified air that's going into these individuals. The trach collar, and you can kind of tell in the way that it sits on this individual in the picture to the left, is a very open system. So, you know, you're not necessarily getting a whole lot of oxygen support, but what you're really, the air that you're kind of throwing into that direction where the tracheostomy is just really there for humidification. You may get a little bit of extra oxygen, but a lot of the air is going to be kind of flowing around the trach. It's really not a closed, tight system like we would need. You know, if that was really necessary, that patient would probably need to be put on a ventilator. There are a lot of benefits to trachs. We have a lot of trach patients in the ICUs. And I know that for me, you know, if you're somebody who isn't comfortable with trachs, which was definitely me for quite some time, something about them just really scared me. You know, the more that I learned about them, the more comfortable I became with them. And so that's definitely something that I would recommend if you're uncomfortable with something, you're not sure that you know how to do trach care, you've never done it before, but you've read about it, you know, certainly grab a colleague, get some practice, seek out the opportunity to really kind of engage in that skill, because it is not difficult, it's just a little scary. The next oxygen delivery system that I want to talk about is high flow nasal cannula. So depending on where you work, you may or may not have ever seen high flow nasal cannula. We do use it a lot in the critical care areas. This is a very good way to deliver oxygen to patients who are really hypoxemic. So these patients who have perhaps a chronic hypoxic disease like interstitial lung disease, or you have a little bit of a worsening of cancer or pulmonary fibrosis. And the high flow nasal cannula really is one of the highest concentrations of FiO2, of oxygen, that we can provide to somebody who is not on a ventilator. In the systems that we use here at UAB, we, for the most part, most of our high flow nasal cannulas are going to come on what's called a blender system. So what that means is, and I'm actually going to toggle over to the whiteboard here for just a second. What that means when we talk about having a blender system is that we essentially have kind of two flow meters, okay? So one of these flow meters is responsible for delivering oxygen. These little black circles are knobs. The other one of these flow meters is responsible for delivering air, okay? And so these two things are, I can dial my oxygen delivery to, you know, let's say 10 liters, okay? So I've got my little floating bowl, I'm at 10 liters, and let's say I'm gonna put my air on 10 liters as well. Okay, so if I'm managing somebody on high flow nasal cannula, this tells me they are on 10 liters of air plus 10 liters of oxygen. So this individual is on a total of 20 liters, okay? Now, the other thing that UAB has, which is very helpful, is something called an analyzer, okay? And what this looks like is basically a little blue and gray box that sits somewhere just below where we would kind of turn these knobs. And when we turn this on, it tells us in this little box exactly what our FiO2 percentage is. Okay, so, you know, rough guess, 10 liters of air, 10 liters of O2, that would tell me that this person is probably somewhere around 50% FiO2. All right. So something I wanted to kind of go into a little bit more detail on this for those of you who haven't seen high flow nasal cannula or aren't familiar with it. One of the things that is important to remember is that respiratory therapy is really kind of owns management of high flow nasal cannula systems. Now, a lot of people ask me, can a nurse manage and titrate high flow nasal cannula? The answer to that is a little bit confusing, but overall, no. The answer to that is no, because of this right here, okay? It is within our scope of practice as a nurse to titrate this. That is to titrate our oxygen. But what it is not in our scope to titrate is this, flow. So when we add air, medical air into the equation, we are adding what's called flow, and that's really respiratory's job. And so because of the way that this system is set up with air plus oxygen, it's really helpful for RT to sort of own, manage and have ownership of the entire system as is. Okay, so let's go back over to our PowerPoint now. And still does that. Really our job when we talk about kind of this high flow nasal cannula is, of course, you know, if we need anything, respiratory is of course there, but the weaning process is really on them. And something to remember, you know, I always want to know as a critical care nurse, I always want to know in the case of an emergency, what would I need to do? So something that's kind of helpful and important to note is this right here. Okay, an increase in air will decrease the oxygen concentration. Okay, a decrease in air will increase the oxygen concentration. Okay, and that makes sense if we go back to this drawing here. If, let's say, I were to take, you know, this 10, and nope, we're going to turn that down to 5 liters. Okay, so I'm going to come down here. Now I'm on 10 liters of air, or 10 liters of oxygen, and only 5 liters of air. That puts me at a total of 15 liters. And when I check on my analyzer, it will probably have me somewhere around, you know, 70% of FiO2. All right. Okay, so let's go back to our PowerPoint every time. Can a nurse titrate high flow nasal cannula? We just talked about that. Okay, another concept that folks tend to have a lot of questions about, BiPAP versus CPAP. So I want to just kind of give some definitions here. And I'm actually going to start with CPAP. I'm going to kind of reverse it from the way it's on the screen. CPAP stands for continuous positive airway pressure. Okay, that is basically continuous, relatively low amounts of pressure that is used to keep the upper airways open. So this is, you know, most probably all of us have taken care of a patient who's got some form of obstructive sleep apnea. And as this person falls asleep, the upper respiratory tract sort of relaxes, and it kind of occludes part of the breathing process. And so what that CPAP does is, you know, blows some positive air, positive pressure, and just kind of helps open that collapsed airway. All right. So if we're looking at kind of where this is on the airway track, and y'all kind of bear with me with the drawings, this is sort of, you know, their mouth here. Okay. And what we're going to do is, okay, so I decided to skip over to the whiteboard over here. So what I've got is basically a really accurate, lovely drawing of an individual, and you can see here we've got their mouth here. So when somebody has obstructive sleep apnea, oftentimes there's an obstruction that's really kind of sticking in the back of the throat somewhere down here. But, you know, the important thing to remember is that this is really very much so in the upper portion of the airway, okay? So that person is going to need something like CPAP. These are people who only wear this at night, and, you know, really doesn't change, you know, a whole lot other than keeping that airway open. So not a lot of pressure going on there. But when we go back and we look at a patient who is on BiPAP, what we see is BiPAP is basically a bi-level positive airway pressure device. So oftentimes we use the term BiPAP to sort of as a sort of umbrella term to refer to non-invasive mechanical ventilation. Okay, so these patients may be on the exact same piece of equipment that we use on individuals who have an endotracheal tube, but it's just non-invasive. So when we talk about BiPAP, the reason that it's called bi-level positive airway pressure is there are two different levels of pressure. Okay, one when I inhale and one when I exhale. So why would I want that is basically two different levels means that it's a little bit more comfortable, and there's two different types of pressures, so it's a little bit more complicated. And why is it more complicated? Why is it more helpful? So CPAP really focusing once again on these kind of upper airways up here. When we add in, we talk about BiPAP, okay, or how I like to refer to it as, you know, non-invasive mechanical ventilation. This is really, I want this air to kind of go, actually, I'm going to do this in blue, okay? I really want this air to go all the way down and really start to get into the actual lungs, okay? And what helps me clarify, that's one of the reasons why I like to refer to it as non-invasive mechanical ventilation, because it reminds me that when somebody is needing bi-level positive airway pressure, this person is actually getting quite a bit of ventilation support, okay? So if we remember what ventilation is, anybody remember what ventilation is? Ventilation is, so ventilation, that's right, the movement of air in and out of the lungs. Okay, so we look about, you know, who's a candidate for these types of therapies. CPAP, we're looking at something, you know, this is pretty standard, pretty obvious. Somebody with obstructive sleep apnea, I've got to get to right here, okay? BiPAP, my goal with BiPAP, on the other hand, is to get all the way down here, okay? So what does that mean? I'm going to have a much, much higher pressure from this BiPAP machine than I am from a CPAP machine. And that's why it's really important that I have an inspiratory, inspiration, and then a different pressure on expiration. Okay, so when I take a deep breath and I inspire, that's where I'm going to get that really nice high pressure system that's going to get me all the way down into my lungs down here, help me breathe, really expand those lungs. And then when it's time to expire right here, that pressure is going to kind of level out. It's going to be dropping a little bit. Okay, and that just really lets the patient expire. If the pressure stayed up really, really high during expiration, that's you know, when we would start to see kind of the mask that's sitting on the patient, and they're breathing out against it, and the mask is just kind of flopping, and air is escaping all around it. That's when we see that situation happening. Okay, so we're gonna switch back over, and I don't know how to make it quit going back to the home screen. I'm sorry, you guys. Okay. All right. So we just talked a little bit about this. The very first introduction to ventilation, the movement of air in and out of the lungs. So what kind of things affect ventilation? All right, things that affect ventilation. This is going to be anything that can limit the diaphragm or the chest wall from moving can alter ventilation. Okay, so this could be a really long list of things, all right? This could be, you know, anything from obesity, okay? This could be, you know, a spinal injury. This could be lung disease. This could be all sorts of things. I could fill up this whole page with reasons that, you know, the diaphragm or the chest wall is not moving like it should, okay? So let's take a little bit of a closer look at how we measure ventilation. All right, so with oxygenation, remember, we had oxygenation, we measured our SpO2, You know, put that pulse ox on their finger, their ear, wherever you can get a good value and a good waveform to indicate that it's accurate. That's how I'm going to measure my oxygenation. With ventilation, we're going to look a little bit more intensely at some things, okay? With ventilation, one of the best ways that we can really effectively measure this is going to be with an arterial blood gas, okay? So when we measure arterial blood gases, and I'm not going to go into too much detail on ABGs here, is I'm really looking for a couple of important values, one of which is my pH, and the other of which is my CO2. Okay, so when we look at things, things that sort of help us measure ventilation, remember this is the movement of air in and out of the lungs. Okay, when we talk about a blood gas, CO2, we breathe off CO2, we exhale this, okay? So if I'm looking at air moving in and out of the lungs, my CO2 levels will give me a pretty good indication of, you know, how fast is this person breathing? Are they taking deep breaths? Things like that. Are they breathing too fast, too slow? Kind of help me answer all those questions. And then, of course, my pH gives me a little bit more information on how well the patient's doing overall. So, you know, I am not going to spend a whole lot of time, like I said, talking about arterial blood gases. I think on the next slide I've got a link to a really good resource that if you want to learn more about ABGs, you can do that. And probably, you know, blood gases that, depending on what kind of patients you take care of, you may be a little bit more familiar with is the venous blood gas or a mixed venous blood gas, especially if you work in some of the cardiac areas. And I just want to make an important distinction between venous gases and arterial gases. Now, of course, you know, arterial blood gases are going to be coming from an artery. Venous gases are, of course, coming from veins. But the biggest difference in these two, other than where they're drawn from, is the arterial blood gas is really going to give us information about oxygen being provided to the tissues and organs, okay? When we look at venous gases, whether it's a venous blood gas or a mixed venous blood gas, this is really giving us information in regards to the patient's oxygen consumption, okay? Do y'all hear that difference there? Arterial blood gas being what's being delivered and venous blood gas being what's being consumed. So that gives us a little bit, little different pieces of information. Okay, so this is just a brief reminder. This is kind of the chart that we use when we look at blood gases. And really the most important question that I tend to ask myself is, when I look at a blood gas, is what is the pH, okay? And you can see here below this AACN.org, the free COVID-19 pulmonary ARDS and ventilator resources. There are several sections to this course online. The very first section of it is about arterial blood gas interpretation. So if you'd like to learn more about that, you're welcome to use that link. Please know that you are not going to be responsible for interpreting and deciding treatment of individuals with, you know, who have blood gases drawn. So let me go back to this pH thing here. So what is the pH? Okay, so I'm gonna use two patients that I'm gonna make up. Okay, one person has really terrible interstitial lung disease. They've got you know, chronic respiratory failure. That looks like renal failure. Okay, well, whatever. They have chronic respiratory failure, and then I'm going to use me as the other patient. Okay, so relatively healthy adult with no major lung problems. So let's say this person with really bad respiratory disease here, you know, they're walking around with their PA CO2, so their carbon dioxide from their blood gas, is, let's say, 65. Okay? My PaCO2 in this scenario is also, sorry about that, is also going to be 65. Okay? So in this scenario where you have a relatively healthy adult, if my CO2 were, all of a sudden 65, I'm not going to look so good. Okay, this is going to be me. I'm probably going to be kind of obtunded. I'm probably not looking very good. I might even be unconscious. I'm probably going to need some support ventilating. Okay, and when I look at the pH for me, it's going to support that. My pH, if my CO2 were all of a sudden 65, would probably be, pretty low. So if we look at, normal values for this, our PaCO2 somewhere between 35 and 45, pH somewhere between 7.35 and 7.45. So at 7.1, I'm pretty, pretty far below the normal limit, and I'm probably not doing so well. Now this individual whose PaCO2 is 65, but they sort of live with this long-term lung disease, lots of, chronic pulmonary issues. When we look at their pH is 7.41. Okay, so what this tells me is a little bit about, or what this should indicate to you is that, yes, the PaCO2 is an important number to be looking at. So is this HCO3. That's going to be your bicarb. But most importantly, I really want to pay attention to this number, this pH. Okay. Now, because if I got a CO2 of 65 and just said, oh my gosh, their CO2 is 65, well, that information doesn't actually give me anything. But if you tell me, oh my gosh, their pH is 7.1, that tells me something very important, which is that this individual is really sick and needs some intervention. So when you're looking at blood gases, and like I said, you can get a lot more practice. Something that I always, tell people to pay attention to is what is the pH? Because that gives me an indication of how sick is this person really, and what should I be expecting. If I've got a pH of 6.9, I'm going to start to be worried that, this person, might code in the imminent future, and I need to be prepared for that. But you can always call physician, respiratory therapist, another nurse to help kind of interpret the data that is on the results. As far as drawing arterial blood gases, if it needs to be obtained, this is not something that you need to be expected to do. There are a couple ways that we do this. One is by an arterial stick. So this would just be a straight stick into an artery. This can be done by a trained RN or a trained respiratory therapist, and depending on where you're working, that some ICUs, some intensive care units have nurses that can do it, and in some ICUs, the respiratory therapists, they do it. And then the other way that this can be obtained is through an arterial line. So we're not going to talk about arterial lines in this presentation. I know that it's talked about in some different talks, but just remember, if an RBG is needed, this is definitely something that coming from an acute care area that you can delegate this either to an ICU RN, respiratory therapist, or a provider. And the same thing with the arterial blood gas results. I have included a little bit about the system that we use to collect arterial blood gases. If you'd like to observe that, this is just a video from Edwards, which makes the device that we utilize here. You're welcome to do so, but keep in mind this is not going to be a skill that you're expected to perform. Okay. Last but definitely not least, we are going to spend a little bit of time talking about mechanical ventilation. This is probably the area that most people feel the most uncomfortable with. I know when I made the transition from acute care to critical care, ventilators were something that I didn't understand. They scared me. I didn't really have any idea what was happening with them. They make a lot of noise. There's alarms going off all the time. I can remember for probably the first 8 months or so of my ICU experience, I would get in my car after work, or I would lay in bed at night after work, and I would just constantly hear ventilator alarms. So I do want to spend a little bit of time kind of talking about some kind of the basics of how mechanical ventilation works. But something that I really want you guys to understand is that you are not expected to know how to manipulate the ventilator. Okay, these are resources for comfort. So you have some kind of idea of what's happening with these patients. We rely heavily on respiratory therapy to manage our ventilators. That's actually the protocol that we use, respiratory therapy to manage the vent. And so even if I have to call the respiratory therapist every 5 minutes for something with a patient on the ventilator, that's what I'll do. I did include the training website for the ventilators that we use. This is a Medtronic website, and there's quite a few tutorials and videos and things like that are on there, which may be helpful if this is something that you have additional interest in learning about. Okay, so let's one last thing actually on this slide is you'll notice that I have right here modes, volume control, and pressure control. So what we're going to talk about is there are two primary functions when we're artificially delivering breaths to people. One is with a volume control and one is with a pressure control. And we're going to spend a little bit of time kind of diving into that because it's a really helpful concept to understand. Okay, so next I just want to go over kind of a basic review of ventilation and then what happens when we kind of add in the aspect of mechanical ventilation. So before we talk about altering ventilation and mechanical ventilation, something that's really helpful to know is how do we ventilate normally? So kind of the way that I like to demonstrate this or explain this is that if everybody will just humor me and take a deep breath, wherever you are, you're at home, you're in your car, you're checking out in the grocery store line, whatever, and just take a very, very deep breath. Okay, so why does air come into our lungs when we take a very deep breath? Okay, basically what happens is the diaphragm contracts, and when the diaphragm contracts, it creates a negative pressure system in our lungs, and that lets air sort of move down into the lungs, okay? So we're essentially sucking air out of the atmosphere and into our lungs to help our lungs inflate. All right, and that's very, very different than what happens when we practice what's called positive pressure ventilation. Okay, so remember, when someone's breathing spontaneously, you and I walking around the hallways, we're breathing normally. Normally we breathe in a negative pressure system, okay? When we add mechanical ventilation into this equation, we then take that negative pressure system and we flip it completely opposite, and we're now ventilating somebody in a positive pressure ventilation system. Okay, so what does that mean? That means that air is basically applied at the patient's airways and it just forces gas into the lungs. Okay, so think just for a second, humor me. Think about how uncomfortable it would be for air to be forced into your lungs, whether or not you wanted air in your lungs to begin with. So when we talk about people being really uncomfortable when they're on the ventilator, this is a pretty prominent reason that that happens. Is yes, they may have, you know, an endotracheal tube that goes through their mouth down into their lungs. You know, that can be extremely uncomfortable, kind of sitting on that cough and that gag reflex. But also the positive pressure aspect of mechanical ventilation can be very, very uncomfortable. So, you know, when we add that in, that is reasons that people oftentimes need to be sedated on some type of continuous um, sedation or anesthetic type medication when they're being mechanically ventilated, is to kind of help them sort of not fight the ventilator quite as much. Okay, so if you're, you know, shoving a bunch of air into my lungs and I don't want that air, my natural instinct, my reflex there is to fight the ventilator, and that's not what we want. You know, we put people on ventilators when we need to help, you know, supplement what they can do on their own. Um, so, um, okay, so next let's talk about some basics of mechanical ventilation. The first thing that we're going to set on a ventilator is what's called basically the respiratory rate that the patient is going to get. And, you know, in the first slide of mechanical ventilation, we talked about things either being a volume setting or a pressure setting. So let's take just a second to kind of, I want to take just a second to sort of explain a little bit more of what that means. So what I'm going to do is basically, I'm going to draw two different patients here. So these are lungs. Those are not very good lungs. You know what? And then we're going to call this is patient A, okay? And this over here, this is patient B. So here's what we know about patient A and patient B, okay? Both patient A and patient B are, you know, 65-year-old males, and they are both on the ventilator, okay? Now, patient A is a young 65-year-old. He is active. He's got young, you know, good, healthy lungs. And patient B here, so we're going to say this guy has pretty healthy lungs here. So you'll notice that these lungs over by patient A are a lot larger than the ones over by patient B. Larger meaning that they're healthy, they can expand well, they can, you know, they don't trap air like in COPD, they can exhale well. And patient B, you know, you can see has much smaller lungs. And we'll say patient B over here has a pulmonary fibrosis, and a type of interstitial lung disease. Okay, so the way that mechanical ventilation works is that we're going to start with talking about volume, okay? So in a volume control, basically what that means is that the ventilator is going to give a set amount of volume, okay? And this volume here is going to be measured in mLs or cc's. And what that looks like is that if I am just looking at patient A and patient B, they're going to be on the same ventilator setting. They are going to be on a volume control, okay, VC for VC. And they're going to be somewhere, let's say 500 mLs of air, okay? And let me just erase that line. All right, so now I've got a see, did I fix that? Oh gosh. Let me adjust. Take a second, get this formatting right. Okay, so they've got, this volume control, 500 milliliters. And what that means is this here would be the amount of air, the volume being delivered every single breath. So how do I know how many breaths to be taken? And we'll kind of go over a little bit more of this on the PowerPoint, is the ventilator, we're going to typically see this in the ICU, oftentimes set at what is called AC, which stands for assist or control. So all that means is that the ventilator is either completely controlling the breath without any of the patient's help at all, or the ventilator is responsible for assisting any of the patient's efforts to get it to the set rate. So when we see the letters AC for assist control, what that means is that essentially this person has a set respiratory rate on the ventilator. Okay, so for this particular patient, we're going to go ahead and we're just going to choose 20 breaths per minute. So if I have a patient who's on AC VC, which is the way that we would say that, at 20 breaths per minute at 500 milliliters per breath, that means that 20 times per minute, this ventilator is going to deliver 500 cc's of air into this patient, okay? And so what we're going to look at is both patient A here and patient B are both going to be on these ventilator settings, okay? They're both going to be on AC, VC at 20 and 500, all right? So let's take a second to compare these two sets of lungs. So what do we know about patient A lungs versus patient B lungs? Okay, patient A's lungs are much healthier. They more easily expand. They've got larger volume, larger surface area for the volume to fill up. And patient B's lungs are kind of stiff and smaller and don't necessarily, definitely not going to expand quite as well as patient A lungs. So both of these individuals are going to get 500 cc's of volume, okay? So, and that's not into one lung, that should be into both lungs. So we'll say, 500 cc's of volume right there, 500 cc's of volume for patient B as well. Okay, so now let's take a second and look at these patients. Now, is patient A or patient B, what I want to talk to y'all about is the workload of the ventilator. Is it going to be easier for 500 cc's of air to fit into patient A right here, or 500 cc's of air to fit into patient B? Okay, so let's take a minute and answer in the chat box what it is that you guys think that. Right, patient A. Okay, I know that sounds maybe kind of too simple, but this is a really important concept, which is why I'm going to kind of focus in on it pretty well. Because what we're looking at is the thing that changes. I'm going to be on the exact same ventilator settings, AC, VC, 20, 500 for both of these patients. But the thing that changes is how hard does the ventilator have to work, okay? Patient B, that's a lot of work from the vent, okay? That's a lot of work. So when we talk about work from the ventilator, what does that mean? What does that equal out to? So work from the ventilator, high work from the ventilator basically means the ventilator has to put more pressure into lungs in order to get to this 100 cc's, okay? Patient A, these lungs are really nice and big and they inflate very well. So the ventilator doesn't have to work very hard, which means that it's got a pretty low pressure system, all right? So what does that equal out to? It equals out to in volume control. Okay, your volume is always constant. And it won't be exactly 500 cc's of air every single time, but it will be very close to that. It will be somewhere around that, 480, 513, you know, something very close to that. Your volume is always constant, and your pressure is always going to be variable. So your pressure is changing from patient to patient, from breath to breath. The ventilator is reading how hard do I have to push in order to get these lungs to expand and take all 500 cc's of air. I've been told it's my job to get 500 cc's of air into these lungs. How hard do I have to work? Okay? And so that's something when I look at a ventilator and I have a patient who's in volume control, you know, if I'm just looking at the patient, I don't know exactly how big their lungs are. I don't know what their lung capacity looks like necessarily. And so what I can do is based off of how high the pressure is, how hard the ventilator has to work in order to deliver the volume that I've asked it to deliver, gives me a little bit of an indication as to what might be going on with this patient. So it gives me a little bit of help with indication. Okay, so now I want to take a minute and, you know, we're actually going to, I'm going to kind of back up, and we're going to go all the way back to the basics. And instead of volume control, so I'm going to leave this part up here. I'm going to leave this part up here, but we're going to get rid of everything else. And what we're going to have is the same patient. I've got patient A, nice big healthy lungs. Patient B, who still has pulmonary fibrosis. So same two patients. I'm going to keep the exact same respiratory rate. However, instead of a set volume, so this is what we call it a set volume of 500 cc's. Instead, I'm going to have a set pressure. Okay, so this is what we refer to as a pressure control type of ventilation. All right, so what that means is there's a set amount of pressure. So, and we'll just kind of pick a kind of an arbitrary number here. I'm going to say 15. Okay. All right, so set amount of pressure. What does that mean? That means that my pressure here, okay, is going to always be constant. So let's look at the job of the ventilator in these two patients. I've got patient A up here with the nice healthy lungs. Let's say for 15 of pressure going in, so 15. Now, what I don't know is how much are those lungs going to expand with this much pressure going into it. So this is a completely made up number. There is no formula that I'm using or mathematical equation, but let's say for patient A, what that means is that this person took 700 cc's of air in with their breath, okay? All right, now for patient B, who gets 15 of pressure, they only took 250 cc's of air in with their breath. Okay, so what have you noticed that's different this time? So constant pressure, we got 15 and 15 here, but the thing that's very different between these two patients is now the amount of volume, okay? Oops. So what does that look like? In volume control, up here, I've got my volume being constant. My pressure is the thing that changes. In pressure control, I've got my pressure is always constant. It's always going to be 15 in this scenario. But the thing that changes, breath to breath, patient to patient, is going to be my volume. Okay, so let's jump back over to the PowerPoint, and you'll kind of see why I've spent quite a bit of time on this particular concept, because I think it is a helpful one to understand. Okay, so we've talked about assist control. That's an important subject to kind of understand, and talked a little bit about this volume control and this pressure control. And the next mode of ventilation here, this patient differences was the patient A and patient B that we've talked about. The next mode of ventilation here, so SIMV, synchronized intermittent mandatory ventilation, what that means is that this would be the mode of ventilation instead of assist control. You would have a patient on SIMV. And just like in AC, assist control, where I can either have volume control or pressure control, SIMV, you can either have volume control or pressure control. So essentially what SIMV means is just exactly what it stands for, synchronized intermittent mandatory ventilation. So translated, that essentially says the patient can breathe on their own. If they're not breathing adequately, the ventilator is there to help. Intermittently, it can be there. This is a really common mode of ventilation that you see in patients who are perhaps waking up from surgery. So someone going from very deep anesthesia where the ventilator is doing lots of mandatory ventilation to someone who is waking up and trying to get off the ventilator, where the ventilator is really not needed very much. Okay, and there's kind of the same explanations of volume control and pressure control that we looked at with assist control. So I'm not going to go into too much detail about this. The information there is really more for reference. One of the other modes of ventilation that you might see is a spontaneous mode of ventilation. And essentially what that stands for is the patient is inhaling every breath on their own. Now, you'll see this definition says patient is breathing totally on their own, okay? I actually don't like that definition very much because on a spontaneous setting, do you guys, let's go back a couple slides where we talked about positive and negative pressure ventilation. What the ventilator reads is that patient's trying to initiate a breath. It reads that negative pressure of that patient trying and starting to inhale, and then the ventilator kicks in and gives that patient just a little bit of help to really, really assist in getting those lungs inflated, okay? So on spontaneous, this patient does not have a set respiratory rate. They are responsible for initiating all the breaths. However, they may have some different support as far as pressure support and PEEP. And talk a little bit about what PEEP is here in a minute as we keep going. I wanted to include some screenshots of what our ventilators look like. So what you'll notice, these screens are very, very different looking. And this is really sort of provider preference. Okay, this screen over here on the left, if you are taking care of a patient, we're using this a lot in our COVID-19 patients where we really need to be able to see the ventilator clearly from the door. I need to see what those numbers are clearly from the door without necessarily going in the room. This is a very good option. The numbers are much larger. And then this screen over here on the right is a very classic looking screen where I've got pressure waveform on the top of volume waveform. And I want to take just a moment to sort of go over where some of these values are. You'll notice the big C up in the left-hand corner of each of these ventilators. What that means is that is a controlled breath. So that means that the ventilator is doing all of the breathing in this situation. And you'll notice that creates actually a green line right here, okay? A green waveform. That's what we're looking at. You can see that green waveform on both of these screens. And that's very different than this screen, which is an S, so S for spontaneous, which also shows up in a red color on the waveform on the ventilator. And I think it's also helpful to take just a quick moment to look at sort of the way that this is set up and try to get a really good view here. Now, we'll start with the very top line here that I'm circling, okay? So probably the most important numbers for us to pay attention to at all is this first number. That is the pressure in the lungs, okay? Pressure in the lungs. This, FTOT, and there's another slide that kind of shows you this a little bit in better detail, is our respiratory rate, okay? VTE is our volume. So how much volume was taken in that breath. And what's good to kind of differentiate is that there are some other numbers up here that we're not going to spend very much time talking about. But this bar up here, this is going to be what is your patient actually doing, all right? And then these down here at the bottom of the screen, which unfortunately this person's hand is kind of in the way, but these down here at the bottom of the screen, this is the ventilator settings themselves. This is what I have asked the ventilator to do. And this is what it can actually do and what it's reading off the patient. So get a good picture of this. These should roughly match, but they don't always line up. Something that is helpful for you guys to know is two main functions that you may be expected to know what they are and know how they work. Is that top button? You can't see it very well. It is an alarm bell. Okay, so that is the silence button. Okay, so if the ventilator is alarming and someone needs it to be quiet, you can hit the silence button. Certainly don't hit the silence button if you're not sure why it's alarming. And then the button right below that says O2. So this is 100% oxygen for 2 minutes. So this is really helpful if you have a patient who is, desaturating or is going to be suctioned and things like that. All right, I'm not going to go into a whole lot of detail on ventilator alarms, but something that you will notice is that each ventilator alarm has kind of a funky abbreviation attached. VTE is tidal volume, VETOT, minute volume. So they don't right off the bat tell you exactly what it's, what it does say tidal volume, it'll say TE. So it's nice to know exactly what those alarms are trying to communicate. And these charts that are in here are really for your reference later on, if and when you interact with a ventilator. And it gives you kind of the alarms that you may experience, possible causes of those alarms, and then some recommended actions, troubleshootings, things like that. Okay. Now, I'm not going to go into detail with each of them. You are going to have respiratory therapy. You're going to have, a colleague around who can help you sort of troubleshoot these things. Most of these parameters of ventilation are going to all be things that we have talked about already. So we've got our respiratory rate. Of course, we would see that. And tidal volume, we've talked a little bit about that. So pressure control settings, we've talked a little bit about that. Flow rate, this is really dependent on respiratory therapy. We don't spend a lot of time in nursing communicating about flow rates. Of course, FiO2, that is something that we talk a lot about in nursing. And then pressure support and PEEP. So I want to spend just a little bit of time talking about PEEP. So let's go back. Let's swap back over to this whiteboard just for a second, and I'm just gonna erase some of this stuff. So when we talk about the ventilator, when we talk about PEEP, some of you may remember this from nursing school, or you may have talked about PEEP in other functions. When we talk about PEEP, first off, we're going to look at what is PEEP. What does PEEP stand for? So what that stands for is positive end expiratory pressure. So what does that mean? Okay, so when we looked at the ventilator, we saw some kind of waveforms that looked something like this, okay? What those waveforms mean is this is inspiration. Right here, I'm taking a deep breath in, and then I'm kind of breathing it out. And this is kind of the expiration here, okay? And this space between breaths. So what I want to know when we look at the function of inspiration is what happens in a normal kind of alveoli. All right, this is my alveoli. It looks like a cloud down here. And in normal alveoli, the way that I think about this is very similar to a door closing and opening. Okay, when the door, when we take a deep breath in, when we inhale here, that door opens. That door opens up, gas exchange occurs, and oxygen gets to oxygen and carbon dioxide get to kind of do all their stuff, and we exhale. Carbon dioxide gets breathed out, and then we start the process all over again. Okay, the door open, the open door allows for gas exchange to occur, oxygen to get into the body, get into the bloodstream, carbon dioxide to get out. Okay, when the door closes, these alveoli kind of collapse, and when I take a deep breath in, they reopen. When I exhale, they close back down. And so I picture it like a door opening and closing. Now, that's how alveoli work when somebody is healthy, when they have healthy lungs. But if somebody is sick, okay, let's say they've got pneumonia, let's say they've got ARDS, acute respiratory distress syndrome. What this looks like is lots of fluid and maybe edema and really just kind of a lot of infected looking junk maybe building up in the lungs. So when we talk about things building up in the lungs, when we talk about atelectasis, where that's starting to happen is really at the alveolar level. Okay, so as this door closes, it's going to begin, that door is closed, it's now trying to reopen, but instead of it being easy to reopen like a nice healthy lung, what's happened instead is it's reopening and it's kind of getting stuck together. It's got thick, goopy goo, making it harder and harder and harder for the door to open. Okay, so instead, where that door started opening right here at the beginning of inspiration, now I've spent all this time just trying to get the door open. So now I only have this much benefit of oxygen coming into my system. Okay, So I start to lose a little bit of time oxygen into my body. So that's why fluid in the lungs, pneumonia, ARDS, any type of lung infection where gunk is really starting to build up and you're starting to see lots of atelectasis can be really dangerous because it really inhibits the body's ability for oxygenation and ventilation. All right, so what's our solution to that? Okay, well, we're trying to get rid of the fluid on the lungs, but something else that we can do is we're going to say you can't close the door all the way. All right, instead of closing the door all the way, we're going to stop it when it's about halfway closed. And so that way, that door doesn't have an opportunity to close all the way and get stuck together. When it's only closed halfway, it becomes much easier for us to reopen that door or reopen those alveoli in order to allow gas exchange to occur. So that's what we mean when we talk about positive end expiratory pressure. Okay, we apply pressure to these alveoli so that they can't close, they can't collapse, the door can't be shut, so that it's easier for it to reopen. All right, so why is that really, really important? Okay, let's say that I have somebody with very severe ARDS, okay? They are very sick. They've got, let me get a little bit of a and infection and just, overall just junk kind of surrounding these alveoli and all up in them. And, excuse me, and our solution to that is, okay, we're going to give you some medicine to try and take care of this infection and this fluid and all that stuff. But also what we're going to do is we're going to apply lots and lots and lots and lots of pressure here. These are plus signs, not signs. Positive pressure, positive pressure, positive pressure, so that these alveoli are being pushed really, really far out, okay? So there's a couple risks here. One of which is that I apply too much pressure, way too much pressure for this alveoli to handle. And in that case, what happens is too much pressure, the alveoli is going to burst. It's going to rupture. And what does that end up looking like? That ends up looking like a pneumothorax, okay? That ends up with air in the pleural space. So that's not good. The other side of that is if all of a sudden this pressure is all taken away, okay? All taken away. Oh, there we go. And, the pressure that's keeping that alveoli open gets removed very suddenly. So now the door that hasn't slammed shut, it's going to be very, very difficult for that door to reopen completely. Okay, so that is what we struggle with when we talk about alveolar recruitment. Okay, and versus alveolar collapse. So if you want to learn more about that, you can kind of look up some of these terms: alveolar recruitment, alveolar collapse, in relation to PEEP. Basically, what I want you to take away from this is that patients who are on really elevated values of PEEP, something greater than or equal to 10, we really need to be careful with their ventilation status. When we start getting greater than or equal to 16, 18 of PEEP, then we start getting even a little bit more nervous, and it becomes really important that the ventilators stay very closely attached to the ET tube. Okay, if that ET tube were to suddenly get disconnected, we would lose all of this positive pressure that's helping keep those airways open. And when the airways collapse, they have a difficult time reopening. What happens to our gas exchange? It gets much worse. And what happens to our oxygenation? It gets much worse. So that's just sort of a safety plug on PEEP. Let's kind of switch back over and back to this PowerPoint. All right, so we talked a little bit about pressure in the lungs. I am not going to get into details on that. Continue to measure volumes. We talked about these. I'm not going to spend any time talking about plateau pressures and auto PEEPs. Those are really more advanced concepts that really, to be honest with you, and we even talk about for ICU nurse either. This is a really good screen. Now, this is a picture of our older ventilators. This is the Puritan Bennett 840. Now we use the Bennett 980, which the Medtronic link is earlier in the presentation, like I talked about. But the screens are very similar, which is why I wanted to include this. And it really tells you, all the parameters that would be helpful for you to know are all sort of labeled in here. Okay. All right, so the biggest takeaways that I have for you when you're managing a patient who is on a ventilator and you're not super comfortable with the ventilator, which, you know, don't let people fool you if folks are not comfortable with the ventilator. The ventilator is going to alarm. For those of you who work on telemetry floors, you know that the telemetry monitor is going to alarm. Okay, the telemetry monitor wants everything to be perfect. It wants to see an absolutely perfect sinus rhythm, and hardly anybody, you know, and I would say probably nobody lives in a perfect sinus rhythm all the time. The ventilator is very similar. It's going to allow some slight variation, but for the most part, it wants perfection. Okay. Those alarms don't necessarily mean that something bad is happening. Right? There are yellow alarms on the ventilator. There's on the ventilator. Sometimes you need to intervene. Sometimes you don't. And alarms will definitely happen when you know, if a patient is coughing or taking too deep of a breath, or in a variety of other very normal activities. A lot of it is patient specific on whether or not it's dangerous for your patient or whether or not everything's okay. And so I really just encourage you to utilize your resources, utilize your respiratory therapist, and rely on, you know, your colleagues around you to kind of help walk you through the process. And of course, if, you know, alarm goes off and a patient begins to have changes in their oxygenation or their pressure, often, you know, this is time for intervention to occur very quickly. Your role with the mechanically ventilated patient, most likely it will be, you know, find the alarm silence button and the oxygenation for 2 minutes button. So we pointed those out a little bit earlier. And these things that you're going to need some hands-on experience in order to feel comfortable with. So if you have the opportunity to shadow, or, you know, have somebody help you the first couple times you do this, it's suctioning a patient on the ventilator. It is necessary to rotate an endotracheal tube when you have a patient who's on the ventilator. We rotate that tube every 4 hours. And then, of course, oral care looks a little bit different when you have an endotracheal tube involved. And then, you know, troubleshooting basic alarms, but of course you're going to have help for that. Like I talked about, respiratory manages most of the ventilators at UAB. Quite honestly, most in the ICU that I work in, the RN actually doesn't even make FiO2 changes. We rely on respiratory to really manage all of that. And if we feel like something needs to be changed, we'll give them a call. We work very, very closely with RP and really rely very, very heavily on them. This is just a link to the endotracheal tube holder that we use. Of course, your only responsibility would be to reposition the tube every couple of hours. The respiratory therapy is really responsible for putting the tube holder on. If it needs to be replaced, anything like that, they're really going to manage for us. Okay, so let's talk very, very briefly about tracheostomies, because most likely, I think many of you have seen a trach before. So this is essentially, you know, a surgical airway that's, or an airway that's placed into a patient's trachea. We trach patients for the very same reasons or similar reasons that we intubate patients. And something that I wanted to just include is sort of what each of these parts of a tracheostomy, and what their function is. So I'm not going to read that to you guys, but that is for your reference if you need it. And then, of course, here's some additional resources from the AACN as far as, you know, suctioning, ET tube care, ventilation, some prone therapy stuff. And if you have any questions, please let me know. I'm more than happy to answer them and get back with you guys on an individual basis. Or if I need to create an addendum to this video, I'm more than happy to do that as well. I really appreciate you guys, and hopefully this helped answer some questions that you may or may not have had in relation to the pulmonary system and mechanical ventilation as a whole.